Chronic diarrhea, abdominal pain, weight loss. Could it be Crohn's disease or ulcerative colitis? Today I'm breaking down these two autoimmune bowel diseases, how they're diagnosed, how they're treated, and why they significantly increase the risk of colon cancer. Crohn's disease and ulcerative colitis are both types of inflammatory bowel disease, or IBD. They are autoimmune conditions, meaning the immune system mistakenly attacks the gastrointestinal tract, causing chronic inflammation. Crohn's disease can affect any part of the gastrointestinal tract, from the mouth to the anus, but it most commonly involves the ileum of the small intestine. Because Crohn's often affects nutrient absorption, patients may also develop malnutrition and anemia. Ulcerative colitis, or UC, is limited to the colon and rectum and causes continuous inflammation starting at the rectum and extending upward. Unlike Crohn's disease, ulcerative colitis does not affect the small intestine. Here's a simple way to remember the difference. Crohn's can affect anywhere in the GI tract and often spares areas in between. Ulcerative colitis affects only the colon in a continuous pattern. To diagnose inflammatory bowel disease, colonoscopy is essential. Intubation of the ileum is especially important when Crohn's disease is suspected. Fecal calprotectin, elevated suggests IBD. Normal or low suggests IBS. CBC may show anemia and thrombocytosis. CRP and ESR are often elevated, indicating inflammation. Corticosteroids for flares. Immunosuppressants. Biologic therapies. Surgery may be needed for complications, but it is not curative. Anti-inflammatory medications. Corticosteroids. Immunosuppressants. Antibiotics when indicated. Pain control and dietary supplementation. In severe cases of ulcerative colitis, surgery can actually be curative. Both Crohn's disease and ulcerative colitis significantly increase the risk of colon cancer, especially when inflammation is long-standing. Chronic inflammation damages colon cells over time. Risk increases with disease duration, extent of colon involvement, family history of colon cancer, iron deficiency anemia, dark or bloody stools, changes in bowel habits, unintentional weight loss, abdominal mass. Colonoscopy is critical. Routine colonoscopy starting at age 45. Earlier and more frequent screening for patients with Crohn's or UC. Surveillance helps identify polyps early before they become cancer. If you or your patient has chronic gastrointestinal symptoms, early evaluation matters. Understanding the difference between Crohn's disease and ulcerative colitis can change outcomes, especially when it comes to preventing colon cancer. Follow for more clear, high-yield medical education.